Our patients are our best teachers, so I'd like to tell you about one of mine. Let's call him Jack. I first met Jack about 4 years ago when he generously allowed a very nervous first-year med student, that was me, talk to and do a history and physical with a real patient, him. Jack had been admitted to the hospital for the 4th time for a heart failure exacerbation. He was 73 years old, he lived alone, he loved his small garden, and as we were talking, he asked me to retrieve a plastic bag from his counter and bring it to him. He then proceeded to lay out 16 pill bottles that he had to manage. He told me that he often didn't have a ride to his doctor, but he was very happy to report that he had stopped putting salt on any of his food, as his doctor had advised. Later, as he was telling me about his diet, he mentioned that he loved to eat canned soups. Little did I know at the time, until my preceptor informed me, that each can of soup has about 1 gram of salt, which is about half of the amount of salt that a heart failure patient should have per day. About 5 months later, I ran into Jack again at the hospital, and he was there again for his 5th admission. And Jack overall taught me that so much of health happens at home, and it's not confined to just a series of events that happen in the hospital. Across the US, there are 20 to 30% of patients who are readmitted to the hospital, just like Jack, for largely preventable reasons that have to do with access and adherence and patient education and lifestyle issues. So a group of us, students, patients, faculty, all got together to create a program called Patient Partners. It's a care transitions program that connects students with patients, and they work together to help improve access to resources and to help manage care at home. Patients first meet their student in the hospital. They get to know each other, they learn about each other's goals, and then after a patient is discharged, the student then does a home visit. They make several follow-up phone calls, and then they touch base with a primary care provider for the patient in the month after discharge. Now, we've been iterating on this model, and we're about 3 years into the program, and so we've now evolved to have transitions that happen from hospital to the skilled nursing facility, and we're also working with patients who are post-hip replacement and post-sepsis as well. One of the key lessons that we learned was that the home visit is a really important part to really understanding what a patient goes through on a daily basis, but it's also logistically challenging. So the next step for us is to incorporate the telehealth visit. Now, we all started this program together so that we could address 2 issues. The first was patient care and to help patients get better, reduce readmissions. And the second was about student education, to have early clinical immersive experiences that also add value to patient care. Now, we started thinking about this because there are so many of these high-touch programs, from care transitions to hotspotting to a number of others. They've proven to be effective, and yet there are so many institutions that don't have these programs or don't have the resources to have them. So we started thinking about how can we bridge this gap? And we realized that there are 80,000 people in our hospitals today across the US who are more than happy to work for free if we point them in the right direction. We call these people medical students. There are 80,000 of us, and we are a highly underutilized resource, and we can both help address challenges that are happening today, as well as, we are the next generation of providers and health systems designers, and our healthcare systems need us to have these programs and need us to have this education. Now, Patient Partners is a part of a broader program called SHIELD, the Stanford Healthcare Innovation and Experiential Learning Directive. In fact, our program director likes to call us agents of SHIELD. That's right. There are a number of programs under the SHIELD umbrella that include health coaching and quality improvement initiatives, post-op navigation, and a number of population health management initiatives as well. Now, this is all part of an even broader program, an initiative across a small but growing number of institutions, because our healthcare system is rapidly changing, and yet our health education programs are largely based off of the Flexner Report, which was published in 1910. We have a real opportunity here to have a resource that helps with helps address patient challenges today, as well as an opportunity to train our next generation of providers who are going to be treating patients and designing systems. And we have this chance to train them in patient-centered care and health systems innovation. So how do we do this? So one, if you are part of Stanford, let's grow SHIELD. If you are a clinical innovator at any institution, let's share our curriculums. If you are a healthcare administrator or an insurance provider, let's integrate these programs into your program operations. Let's all work together and really invest in sustainable programs that put patients like Jack and students like me together from the very first day of medical school. Let's all work together and improve patient care. Thank you.